Good evening for those of you on the East Coast in the United States. Good afternoon if you're in the US on the West Coast, and hi to anybody else who's joined us. This is the latest in a series of webinars on the research programs related to fibrolamellar cancer, sponsored by the Fibrolamellar Cancer Foundation. I'm Mark Furth. I'm the scientific director of the foundation. The title of the webinar tonight is Seeking a Cure, the Promise of Immunotherapy. And I'm absolutely delighted to welcome two really leading experts in the field and two people who've become friends of mine over the past couple of years since I joined the foundation. Paul Thomas, who is a member of the faculty at the St. Jude Children's Research Hospital in Memphis, Tennessee, who's worked in the area of immunology, both for viruses and cancer for his whole career. And Dr. Elizabeth Jaffee from Johns Hopkins. Dr. Jaffee is the Deputy Director of the Comprehensive Cancer Center at Johns Hopkins. She's a professor of oncology and is also a past president of the American Association for Cancer Research in 2018 to 19, and has actually had an important role in cancer policy in the United States, as well as in being a leader in cancer research, particularly in cancer immunotherapy. So we have two terrific people, and if you don't mind, I'm actually going to take the liberty of referring to you by your first names, because we want this to be really an informal conversation. It's geared primarily for patients and caregivers. There are certainly going to be some medical professionals and researchers on the call as well, and we really welcome you. But we'd like to keep the level of discussion to be appropriate for folks who are not necessarily technical experts and certainly not necessarily immunologists. So let's start and talk about the role of the immune system, just in kind of a very broad sense, just briefly. And unfortunately, in a way, but from an educational point of view, maybe it's been a positive side effect of the pandemic. Many of us have become much more aware of what the immune system is all about and what vaccines in particular are. And I was going to start by asking Paul if he could just talk briefly about what we've learned over many years about the immune system that's been relevant medically, both from the vaccine point of view, and then specifically, why is that of interest not to prevent cancer, but maybe to treat cancer?
Sure. The vaccines that we're all familiar with for preventing viral infections and particularly recently for preventing COVID infections are all trying to elicit a part of the immune response called the adaptive immune response. And it's called that because it's the part of the immune system that can both learn and remember. And the goal with the vaccine in that setting is to teach the immune response what something looks like, so that it can recognize it again, remember it, and if you're then challenged with the virus, that you'll be protected from it. And there's two really big arms of the adaptive immune response that we're trying to trigger. The one that gets almost all of the focus in the context of viral immunology, and when you're reading the newspaper about COVID, is the B cell part of the response, because B cells make a protein called antibodies. And antibodies are like targeted little torpedoes that will go out and find the virus. And if you teach your immune system what the virus looks like, it can craft these torpedoes that will keep making for the rest of your life and destroy the virus every time you encounter it again. The other half of the adaptive immune response, though, is the T cell response. And T cells are important for really two reasons. One, they help actually make antibodies a bit. You need T cells to tell B cells to do their job. And then the other reason is that T cells are great at killing infected cells. And so T cells are really the big arm of the immune system that can go around and kill cells that have been co-opted by the virus. And so remove the viral factories that are going to make more virus. And this becomes really relevant in cancer because when you're trying to rid your body of a tumor, what you want is something that kills cells, and you want something that can recognize and kill cancer cells. And so in the same way that we teach the immune system to see a virally infected cell, we can teach the immune system to kill a cancer cell. The reason why we give the vaccine after you have the cancer is because we don't know what cancer you're going to get. We don't know what those cells are going to look like until you have the tumor. And so then you can give what's called a therapeutic vaccine, where while your immune system might at that point have recognized that the tumor cell is something that it doesn't think is quite right, because it is part of your body, the immune system's maybe a little more reluctant to try to get rid of it. And it's different from when you have a virus that's clearly quite foreign. And so the vaccine can help boost that response and really tell your immune system, no, this is something that you don't want. This is just like a virus, and you need to kill the cells that are the factories of the tumor rather than the factories of the virus infection.
Thanks, Paul. That was, I think, a big help for me, at least. I'd like to just fill in something that I should have done earlier and tell folks in the audience that we're planning to have a conversation for about 45 minutes, and then we're going to open things up for another 45 minutes for questions and answers. And the way to ask questions, if you're interested, is through the Q&A function on Zoom. So you should have a box on your Zoom screen. On mine, it's down on the bottom. It says Q&A, and you're able to put in questions there, and we'll try to pick those up and get to those by the end of the evening if we possibly can. So let me turn now to Liz Jaffee and say, I've been in cancer research in some form for a big part of my life now, and I'm certainly the oldest of the three panelists. I can remember back even in the 1970s when I was first getting into research that people were talking about the possibility of immune therapies for cancer. And it was kind of a holy grail in some respect. And there was a little bit of history going back, way back to pre-World War II, but somehow it just wasn't happening. It wasn't giving us any tools that were working in the clinic. And that's changed really dramatically in the last few years. Liz, what's made the change? Why is cancer immunology such a big part of therapy these days? And why is it something that should be of interest to people who are specifically concerned with fibrolamellar carcinoma?
Really great question, Mark. So I think you're exactly right. I think what everyone needs to understand, and it's similar, we had talked a little bit about this before with the COVID vaccines. It's not that all of a sudden things seem to work. It's really builds on 30 years of understanding how the immune system works. People like Paul and myself and others have been in the field for a long time trying to understand how this antibody is produced against a protein expressed by a cancer, how a T cell can actually see a cancer. And so it all started back, as you mentioned, very many years ago, but we really didn't understand that there were even B and T cells until the 1970s. And T cells, we really didn't understand T cells until the 1980s. And that's when we were able to isolate them and grow them in a tissue culture dish and start to really understand how they work, what they recognize, how they recognize. T cells normally recognize viruses. We learned that in the 80s and early 90s, 1990s. But it wasn't until we had all of these new technologies, we're really in a technological revolution right now, where we can sequence things. So as many people know, back around 2000, we were able to, for the first time, sequence the human genome. Well, it took years of technologies to be able to do that. Today, we can actually take a little biopsy from a tumor, and within a week, we can sequence a patient's own tumor and understand what are the proteins in the tumor that make it a tumor, that make the immune system see it differently from a normal cell. Well, by knowing that, we could start to say to ourselves, are there specific proteins that the tumor can display on its surface that a T cell can see? Because we've now learned how a T cell recognizes that tumor. And so that's what we've been doing. And why is fibrolamellar so different from some of the other cancers? Well, fibrolamellar, it turns out, has a specific protein. It's a fusion protein that actually is responsible for the tumor's development. And we were able to figure out that T cells can see these proteins. However, the cancer that expresses this protein hides from the immune system. So what the vaccine does is it provides that protein to the body in a way that it says, hey, this protein is foreign. It looks like a viral protein. You need to react against it. You need to make a good T cell. Then the T cell is made. The T cell can now travel to that tumor, get into the tumor, and it can actually kill the tumor if it expresses that protein. Many of the cancers we work on have lots of these different proteins. We don't know which ones are important, but the science is telling us that in fibrolamellar cancer, this particular fusion protein is very important for the immune system to see. We just have to figure out how to get it to see, how to get the immune system to see this protein.
Thank you. Paul, I know you've done work also on trying to identify proteins that might be candidates for an immune response, and to really ask, are there specific proteins that you can find in a cell? Could you amplify a little bit on what Liz was just talking about, on things you learned about in some of the other pediatric cancers and also in fibrolamellar, that talk about these potential hooks for therapies for cancers that are otherwise very hard to treat immunologically?
Sure, that's a great question. So this is still, really a growing area of research, because we know that the immune system can see tumor cells with their T cells via these very tumor-specific proteins, but we don't know all the rules that makes a particular protein a good protein or a bad protein. But one of the things that seems to be correlated with whether or not something's a good protein to be targeted by your T cell response is that it looks really different from all the normal proteins that you would have in your cell. And so as Liz said, in fibrolamellar and in a lot of pediatric tumors, they're driven by these proteins that are called fusion proteins, where you take two genes and you put them together and that weren't normally together. And so when that happens, at least that part of the protein that's right around where they fuse together looks really different than anything else that's in your body. And so what we found in pediatric tumors and pediatric leukemias is those fusion junctions are often very antigenic, which is a word to mean that it means your T cells can see them more easily. Whereas if you just have, a single mutation, which also occurs in a lot of cancers, where it's just, one amino acid and this whole long list of amino acids that make up a protein, it might not be enough for your T cells to figure out that that's different from the normal protein. Sometimes it is, sometimes it isn't. But we get excited about these fusion proteins because we know there's going to be a lot of differences, and so that's something that the T cell can hold on to. The other reason we get excited about fusion proteins is because they often, as Liz said, they often occur the same way in multiple patients. And so if we start learning the rules about what makes it a good target in one patient, it might apply to other patients because it's exactly the same protein. Now, for a lot of the pediatric tumors we study, it's often a similar protein, but not always exactly the same protein. The fusion doesn't occur in the same spot. And what really makes fibrolamellar a particularly interesting target is that the fusion is always exactly the same. And so the rules that we're learning are hopefully going to be applicable to every fibrolamellar patient in the future.
Thank you. The area that you've just talked about is something that actually at one time really threw me, because I'd grown up in an era in which people were expecting that if something was going to be recognized by the immune system, it had to be on the surface of the cell. And in some cases here, we're talking about proteins that are actually inside the cell. How do those ever get seen by the immune system, and what's the mechanism? They're presumably not things that a standard antibody is ever going to see. So why are we interested in how they're seen, and how do T cells do that magic?
So this is really getting into the immunology now. So the antibodies, as you said, they can't get inside the cell. They're these torpedoes that they're just free floating, and they see what they see, and if they can't stick to it, then that's it. So anything inside the cell is invisible to them. What T cells do for a living, their regular day job, is to go around and survey all the cells in your body constantly to see what's happening inside the cell. And the way that they do that is your cells help them out by chopping up little pieces of everything they're making inside the cell, not, obviously not everything they're making all the time. They just take a small sample of it, chop it up, and they put it back out on the surface of the cell, basically to say, this is what's happening inside the cell. So they completely break down these proteins that are doing some other job, and they take pieces of them and put them on the surface of the cell so that a T cell can come along and say, that I know that protein, it's fine, you can keep making that. In the hopes that if a cell gets infected with a virus, for instance, and it puts a piece of the virus protein on the surface of the cell, the T cell comes along, sees it, and says, you're not supposed to be here, and I'm going to kill this cell so that the viruses can't get out anymore. And in the same way, we're hoping the T cells to teach the T cells with a vaccine to look for these cancer-specific proteins that are being made in the cell, like the FLC fusion protein, that will hopefully get chopped up and put on the cell surface so that the T cell can see it.
So with that introduction, Liz, maybe you could tell us a little bit about the specific work that's being done right now at Johns Hopkins, led by your colleague, Mark Yarchuan, on a clinical trial to ask if a vaccine for fibrolamellar that recognizes the fusion protein, just as we've been hearing, can be done.
Right. So basically, it builds on many, many years of work that many of us in the field have been doing, including my group, for some of the solid tumors that aren't easily treated with the immune checkpoint therapies such as anti-PD-1, anti-PD-L1, and anti-CTLA-4. In fact, if you look at, basically what we've learned that only about 15% of all cancers respond to those checkpoints, those checkpoint inhibitors, those antibodies that actually alter the T cell to make them supercharged to be able to kill a cancer. The reason for that we found is that in the cancers that are responsive to these antibodies, these immune checkpoint antibodies, these cancers display many new proteins that look like they're a virally infected cell. When we talk about many, we're talking about hundreds. And so they easily alert a T cell, and a T cell is ready to go, but they sort of have a stop signal that when you give these antibodies, anti-PD-1, anti-CTLA-4, they inhibit that stop signal, and now the T cell can fully function and kill the cancer. When you take a cancer like fibrolamellar or most other types of cancers, common cancers, they don't have thousands of these new proteins, and that's the problem. But fibrolamellar cancers have, as Paul said, they have this fusion protein that seems to be common among most patients with this cancer because it's the driver of the cancer. And this is typical of many of the pediatric young adult type cancers where they didn't occur over 10, 20, 30, 40 years, but they occurred because of this one specific genetic change. Okay, when you look at a colon cancer in a 50-year-old, it takes 30 to 40 years because it's an accumulation of multiple different genetic changes. Not so with these young people's type of cancers. And so we're taking advantage of the fact that there's this one change, this one new protein that can be viewed as an alert protein by the immune system if the immune system is alerted to it. The problem is, as Paul said, the normal function of cells is to display these small proteins on the surface. And the T cells are looking to see what's new and what's not new. Unfortunately, without a vaccine, even when you give anti-CTLA-4, anti-PD-1, most of the time a T cell thinks that there's nothing new on the surface. So we're educating the T cell to this new protein. So that's what the vaccine does. It educates the T cells in the patient's body to this new protein. The T cells now say, wait a second, that's not normal. Now they get activated, they go into the tumor, and now we give anti-PD-1, anti-CTLA-4, and those act differently. They both help the T cell expand. That's what anti-CTLA-4 does. It helps get a large army of those T cells. And then the anti-PD-1, once it has a large army, is able to get rid of that stop signal and allow the T cells to react against the cancer. So it's really based on what we've learned about the immune system, what we've learned about how the immune system sees cancer or evades the immune system, how cancer evades the immune system. And we're taking advantage of what we know to make sure the immune system is alerted to this new protein.
So if I understand, there's really an interesting combination of ideas here in trying to get the immune system to target a cancer based not just on something that's, quote, a fusion protein, something that makes a new sequence that the immune system can recognize, but you use the word driver. The idea that there are specific mutations that occur that cause the cancer and are required for the cancer to keep growing. And we usually have thought about the notion of targeting drivers with more standard kind of drugs. So there's some great examples. People have heard about protein kinases as drivers of cancers. And there's a whole new collection of drugs that are very specific for particular protein kinases, or even mutant kinases in some cases. Here, you're not depending on the biochemistry, but you're actually using the immune system to target the cancer cell that has the driver. And with fibrolamellar, of course, the driver protein, it happens to be very close to a normal protein that's really important in things like how your heart works. So it's been unclear whether you could make a drug that would be safe, that would just target the kinase activity.
Well, you're right, but there's another point to this that I think you're getting at. And the point of using the immune system is that if you're targeting the driver of the cancer, not only are you eliminating the cancer, but the immune system is smart. So in particular, T cells are smart, so they adapt. Okay, so they can actually change what they see. So if the cancer tries to change that protein a little to try to keep going, the immune system is very quick and it's able to say, hey, wait a second, you can't do that. Also, if you get rid of most of the cancer to the point where you can't see it on a CAT scan, but maybe there's still a few cells left, the immune system's still waiting because the immune system has something called memory. Those T cells have memory. And so as soon as that cancer tries to come back or tries to come back somewhere else, the immune system will say, wait a second, let's get rid of this. So the immune system it's a dynamic process. That's what's wonderful about it, at least this part of the immune system. It has the ability to adapt to changes very quickly once it's been educated to the problem. Whereas with these targeted drugs, unfortunately, when you just target one protein with a drug, they quickly can adapt and that drug no longer is effective. So it escapes the effectiveness of that drug because a drug is not a living cell, right? It can't easily adapt.
And of course, you're not taking the drug necessarily for your entire life. There's some exceptions to that. But in general, the side effect profile of drugs are significant enough that it's not so easy to stay on therapy forever. And right. that raises issues as well. We've brought up the topic of immune checkpoint inhibitors a couple times in passing now, and maybe it would be worth spending a little more time talking about what the successes have been with immune checkpoint inhibitors, why they're interesting, what they are. Paul, could you give us a little bit of a framework for the kinds of cancers that have been responsive to immune checkpoint inhibitors and why?
Sure, I'm happy to, and then I'm sure Liz has a lot of thoughts on this too. But as Liz said, the idea behind the checkpoint inhibitors is that T cells adapt and they learn over time. And one of the things they'll adapt to is if you have an infection, say with a virus that is just not going away, and your T cells are trying to fight it, but it's kind of just turning over at a low level. These are things like the viruses that give you cold sores, or maybe the viruses that give you certain rashes. But they're also not doing you a ton of harm. Your T cells have adapted this program to sort of calm down a little bit and stop tearing everything up, because that's going to cause damage over time too. Your T cells attacking your own body, and so we call that program. Some people call it exhaustion, terminal differentiation, but it's a way for the T cell to just say, what I'm doing isn't really working all that well, and I'm causing a lot of collateral damage, and so I'm just gonna turn this off for a little bit. And that same program happens in cancer, because it's sort of the same thing is happening, where you have maybe a very large tumor where the T cell has actually seen something and is trying to deal with it, and the T cell, maybe there aren't enough T cells, or the tumor's just growing too rapidly, and the T cell just can't keep up, and it triggers that program to say, this isn't working, why don't you turn off? And so one of the ways it does that is it upregulates these proteins on their surface. So it starts putting these proteins on their surface that will deliver a negative signal to the T cell to say, stop what you're doing. And what the checkpoint inhibitors, so those are the checkpoints. They're basically saying, telling the T cell, stop unless the situation changes dramatically. And what the checkpoint inhibitors are they're actually antibodies again, so they can stick to the outside of the cell, and they block the signals coming through those proteins. And they say, why don't you start up again? And so that has worked in a number of tumors. Tumors like melanoma and lung cancer. And again, I think this is an area of a lot of people's research right now to understand why it's working in those, and also, even within patients with melanoma and lung cancer, why it works in some patients and not others. But some of the things that have come out that it seems that helps them to work is you already have a lot of T cells in your tumor that were attacking the tumor. Or you already have T cells somewhere in your body that can recognize the tumor. And so then you can start, then just taking that break off might have a real effect. If you don't have those T cells to begin with anywhere, if they haven't learned what the tumor looks like, then the checkpoint alone is probably not going to be enough. Or if you have too few of those T cells, the checkpoint alone is not going to be enough. You're sort of just telling your immune system to do what it was already doing. And if that's not enough, then it's probably not going to be effective on its own. But in some of these, particularly in some of these tumors, I think are relatively slow growing, enough T cells accumulated that they can actually be reawoken and eliminate the tumor. And so those are the cases in which it's working.
Thanks. Liz Jaffee, the immunologists who began teaching me about where we were in immune therapy of cancer used a language that I found really easy to understand, but didn't always understand conceptually what was behind it. They talk about tumors that are hot or cold with respect to the immune response. The idea of a hot tumor being one the immune system is really good at picking out and attacking, and a cold one would be one that wouldn't necessarily send those signals or evoke that response from the immune system, again, maybe without the help of something like a vaccine. So FLC was always portrayed to me as in a category of cancer that would probably be the very, quote, cold for the immune response. Why is that, and what are you doing to get around that, and what does the vaccine help you overcome that problem?
Right, it's a great question. So when most people talk about hot and cold, I think it's a simplistic way of looking at it, but what they're really saying is there are either T cells in the tumor or they're not. And the 15 to 20% of cancers that have really good responses to our immune checkpoint therapies have T cells sitting in the tumor, or they're sitting in lymph nodes next to the tumor. And as soon as you give the treatment, those T cells, again, are ready. They already know the tumor's there. They know the antigen on the tumor that they want to react to. And once that stop signal or that break is taken off, they go at it. Whereas the problem with fibrolamellar and the 80% of cancers that don't naturally respond to these immune checkpoints is that you can find T cells that have the ability to recognize the cancer and actually kill the cancer, even when you take that stop signal off or you take that break off. And that's the difference. That's why we call them a cold tumor. The problem is it's more complicated than that. We also know that there are a lot of other inflammatory cells that sit in these cancers that actually prevent T cells from functioning. We call them macrophages that are their function under some circumstances is to help clean up infection, clean up any kind of acute process. But the problem is cancers reprogram them. They instruct them to now help the cancer grow. And so they're sitting in there preventing a T cell from getting in and killing the cancer. So that's why we've really had to better understand different cancers. And we're still trying to understand fibrolamellar cancer. We know that it has this stromal component. I mean, you look at a fibrolamellar cancer and it's very stromal. Well, those stromal cells have been instructed, most likely by the cancer cells, to be a barrier, to be a wall against the immune system getting in. So we're trying to learn how to really get through that wall. So a vaccine helps to raise the army of T cells. Some of these immune checkpoint agents help to get those T cells activated and even get into the cancer. However, we also know that we need to better understand how to get rid of that wall. And we're working on that. Many of us are working on that in the field. And you know, from my point of view, I think that's going to be the next area of research that the people on this call will start to hear about, some new treatments that will be able to basically take that wall down.
Great. I've had an image in my head for a couple of years now that comes from some of the Star Wars films of a single lonely soldier and then the Clone Wars, and expanding that one soldier, that one T cell that has exactly the right weapon to get your cancer, and turning it into an army of these very well armed battlers against the tumor. Paul, one of the things I know you've been working on is actually finding ways to create that kind of army for what people call adoptive cell therapy. The idea that maybe you actually want to take patients' cells and make them effective soldiers against the tumor of choice. What's that all about? How would you like to try to do that?
So, so this area has been developing, you know, for decades, really, as you mentioned. So, you know, some of the early studies, people were taking T cells out of tumors and expanding them like the Clone Wars and giving them back to patients. And a lot of times that didn't work. And then sometimes it did work and it would work spectacularly. And so it would keep sort of everybody going saying, well, this can work. We just have to figure out the rules of why it would work. And kind of out of that, that hopefulness, I think, came this development that a lot of people probably heard about CAR T cell therapy. And the idea there is you actually take the patient's T cells and you give them this sort of fake T cell receptor. And the fake T cell receptor is sort of part T cell receptor, which is the thing the T cell uses to find its targets. And it's part antibody. So the C in CAR T cells actually stands for chimeric, because it's this artificial protein that's both an antibody and a T cell receptor. And so it can do anything sort of an antibody can do, but then it tells a T cell to kill the target of the cell of the antibody. And so this has been great for tumors where there's something on the surface of the tumor that we can recognize with an antibody that says that's the tumor and we want to get rid of it. And so the best example of this, the case where it's working the best, is in leukemias and lymphomas that are B cells, and the sort of decoy T cell receptor that's used is an antibody that recognizes all B cells. And when you get treated with these therapies, you actually lose all your B cells. You get rid of all your tumor too, but you also lose all your healthy B cells. The trouble with this approach for something like fibrolamellar is there isn't something on the surface of all the fibrolamellar tumor cells, just a protein that says, I'm a fibrolamellar tumor cell. you can kill me, that isn't also on other cells. So you potentially would cause a lot of other damage, or at least nothing that we've found yet. But as we were talking earlier, there is something on the surface, and it's potentially this little piece of the fusion protein that's being pushed out on the surface so that T cells can come along and look at it. The trouble with this is that T cells don't just look for a little piece of protein. They look for a little piece of protein and another protein that we call HLA or MHC. And the details of this aren't really important, but the trouble with it is that it's a little bit different in everybody. And so some of us have the same HLA or the same MHC, like you're going to have a similar MHC to your parents or your brothers or sisters, but you and I, Mark, probably have different ones. And so we can't use one size fits all therapy if we're going to actually use a T cell receptor to target things that are being made inside the cell. We've got to figure out the T cell receptors that will work for Mark and the T cell receptors that will work for Paul and Liz. And, it's not an infinite list, but it's probably a list of 20 or 30 or 40 T cell receptors that we're going to need, rather than just the one antibody that could work against, all B cells or something like that. And so what we've been working on is trying to find that list. It's not an infinite list, so let's just start working through it. And we found one so far that looks really good, that would help in people that had that particular type of HLA or MHC potentially. But we want, the full list. And one of the ways that, we hope to get that full list is working with Liz and Mark on and people that are doing things to get those T cells to expand another way, so that we can study those T cells, particularly if we know those T cells worked, and say, well, this was a T cell receptor that worked. Now we can just take this and give this to patient and make 1 million cells or 10 million cells with exactly this T cell receptor, give it to them all at once, and hopefully they just wipe out the tumor, in a very quick period.
Right. So I guess what's in common between the vaccine approach and the approach with cell therapy that Paul just talked about is, either way, you're trying to create or make sure that there is as big as possible an army of these cells to battle the cancer, essentially with the same kind of specificity.
Yep.
In either case. But in one case, you're using the vaccine approach to expand it. In the other, you're actually engineering the cells using some of the new tools, and they've become very powerful to change a cell, then expand it and put it back. But either way, the idea is, if I understand it correctly, to go after creating T cells and making sure that they don't have any breaks on them from other sides of the immune system, to create that army and empower it to do its job of attacking tumor cells. And presumably they want to be able to find tumor cells anywhere in the body, not just where a primary tumor is, but they ought to be able to find metastases, maybe even metastases so small you don't even know they're there yet.
I always say, T cells are more sensitive than any instrument we have available to us. And so once you've got this army of T cells, however you make it, if you make it from the vaccine or if you make it through an adoptive cell therapy, they're going to be with you for the rest of your life. And if there's, one lone cell that's still a tumor cell somewhere in your body, the T cells will find that and seek it out.
Great. We're getting close to the point where we want to open up to some of the questions, and there's some very good questions coming in. I wanted to, though, before we get there, ask two things. One is the most important, really, for some of the folks on this call. How do patients and caregivers and their physicians start to make the decision whether immunotherapy or what immunotherapy might be best for them? And especially in a world where we're still very short of data for fibrolamellar, how do you suggest, without giving medical advice, which we're not supposed to do on a call like this, but just strategically, if you're in a patient's shoes or a caregiver's shoes, what should you be thinking about when the subject of immunotherapy comes up and when you want to discuss that with your physicians? Liz, would you like to take a crack at that?
Yeah, it's a tough question. This is a really bad disease, and it's a very tough decision. And unfortunately, like you said, there isn't a lot of data in patients, and no clinical trial will ever enroll lots of patients in this disease. So it's very different from working through, a common cancer like colon cancer, melanoma, or lung cancer. The way I like to look at it, and the way I, talk with my patients with other cancers, is that, I try to explain the science behind how the therapy works. And there are different ways of looking at things. Certainly, sometimes it's mixing drugs together and, based on knowing that it's a tyrosine kinase and maybe a tyrosine kinase inhibitor could work in this cancer. No data necessarily to show that it works in that cancer, but it's a similar protein, so that's reasonable. Sometimes chemotherapy for cancers based on, again, if you know something about the tumor and the tumor has a specific genetic change that a chemotherapy we know will hopefully alter, and you could try that. And then sometimes there's preclinical data where we've been able to isolate the protein, such as fibrolamellar protein, that makes it look different to the immune system compared to the normal proteins. And so we develop vaccines that may target that, and then we give it with agents, immunotherapy agents, that can activate the immune system even further. So I think you have to really understand the science. And I think the best way to do that is to talk with experts, whether it's your oncologist or whether it's someone on the team with the oncologist who might be able to explain it well. There's also sometimes good literature out there. I think we've talked about some of, for immunotherapy, the Cancer Research Institute has a lot of tools to help you understand the immune system and how it works. So it gives you a basis to begin with, at least, so you can understand where someone like myself or Paul is coming from when we talk about our new therapies. I think in this cancer, you want to try different therapies based on good science that tells you that there's a chance it's going to work and that the benefits outweigh the risk. Every treatment has a risk. Aspirin has a risk. People can bleed from aspirin. Most people won't. Once in a while, a person will, and it can be a pretty bad bleed. So every single thing has a risk. Antibiotics have a risk. You can have an allergic reaction and die. But how often does this happen? It's rare. So I really hope that there isn't misinformation about immune agents. Yes, immune agents have toxicities. So does every other therapy that we have in our armamentarium for treating cancer. Okay, you got to understand that all of these have risks, but if the right physician is treating you, they know how to minimize those risks. We minimize immunotherapy risks. We're able to identify when someone is having a risk, and we can immediately prevent that risk from getting very bad. But a doctor who doesn't know how to do that may not be able to minimize the risk.
Thank you. So one of the questions that came through is a broad general one, and I'm not sure if it was intended to be specifically for fibrolamellar or for more broadly for cancer in general, but it's just, what's the reality of immunotherapy right now? And Liz, could you give us really just kind of a capsule? Where do we stand today? And knowing that it's a very dynamic field, and so today's answer and tomorrow's answer might be different. But
So the two major agents for immunotherapy that have been approved that are antibodies are the anti-PD-1 family of antibodies and the anti-CTLA-4. And they have revolutionized cancers. They have taken lung cancers, probably about 30% of lung cancers. They've taken about 50% of melanomas, and then a small number of other cancers, and turned them from death sentences to chronic diseases. Imagine having metastatic melanoma, metastatic lung cancer, you're likely going to die within a year, and all of a sudden you're living 5 years and a good quality of life. And yes, there are side effects, but we can treat them and we can anticipate them and treat them early. These people have a great quality of life. I can't tell you how many of our patients have experienced this. We would have never, ever believed that that was the case. I've been doing this for 35 years. And the past, 8 to 10 years have just changed how I view cancer therapy, and it's because of immunotherapy. And I think Paul will tell you the same thing about CAR T cells and these certain leukemias that are B-cell leukemias. The problem is it only works in a small percentage of cancers. Only about 15% of patients have that long-term benefit right now. But that's because we only understand a small part of how to best activate a good immune system. And we're learning from testing these new therapies in our patients with other cancers by adding vaccines, by adding new antibodies that not only are able to prevent the stop signal or the break on these T cells, but we also know that there are acceleration signals too. And we can actually give antibodies to these acceleration signals. And we're seeing this in bad cancers like pancreatic cancer, where all of a sudden we're turning these cancers into more chronic diseases. So I think we're at the verge of really seeing the next wave of new agents. We're going to see a number of new agents that are going to be available. We're just learning that even metabolism is important. So metabolism, like sugars in cancer cells are altered, and we now can reverse that. So we can combine agents that alter the metabolism of a cancer cell and give it with immunotherapy. We know that the microbiome probably affects a lot of the therapies, not just immunotherapy, but affects chemotherapy. It affects how the cancer grows. We're learning how to alter the microbiome. What is the microbiome? It's the bacteria that are in your gut. We have normal bacteria in your colon, in your small intestine, in your colon. Those bacteria are often altered in cancer. We're learning how to better alter them back to a form that can help be anti-cancer. So there's a lot of new therapies that are going to be coming about in the next 5 to 10 years. The goal with something like fibrolamellar cancer, bad cancer, is to turn it into a chronic disease for now until we have some of these better therapies that can even help even further and hopefully eventually result in cures like we have in a small percentage of melanomas and lung cancers.
I think, as you pointed out, and Paul pointed out, for some of these cancers that are very characteristically found in younger folks, in teenagers and young adults, of which fibrolamellar is a very good example, they have this peculiar property of having, in some of them, and fibrolamellar being an extreme example, the same genetic change over and over and over from patient to patient. Some estimates are that 99% of fibrolamellar patients have that fusion protein we talked about. Paul, I think in the T-cell leukemia you were talking about, it's also a high percentage of patients, and some of the sarcomas similarly.
Exactly.
So if you can find a handle on that, there is at least some reason to hope that it won't be 15%, but you'll have much higher response rates once you actually get it right. And Liz, maybe you could talk for just a couple minutes without, again, getting into more detail than is appropriate for an ongoing clinical trial. But just where are we with the clinical trial at Johns Hopkins of a peptide vaccine for fibrolamellar?
Right. So first of all, it is very safe. We've had no one have any major problems from the therapy, from the vaccine plus the anti-CTLA-4 and anti-PD-1. There's been 8 patients treated, and 6 of them have had some benefit. I don't want to, it's not fair to provide any more information.
Yeah, no, I understand, but that's not necessarily the word that's been kind of out there in just the chat room circle, and I think it's important that you have a chance to say that.
I think chat rooms are nice, they're supportive, and I think that's a very important part of the chat room, but I really want to try to, really make the case for getting the right information. There's so much information out there, and a lot of it is misinformation, just like with the COVID vaccines. COVID vaccines are safe. We are going to save lives with the COVID vaccine. It's already been shown. Okay. And I just don't understand all of the misinformation. And I actually think it's unethical for people to be spreading misinformation. I think you have to ask experts for the information. And I think chat rooms should be supportive, but they're not. There aren't experts in chat rooms. Chat rooms can only give you general information anyway. So if you want the true information, ask the experts. If you want to know about our clinical trial, call our team. They'll tell you about the safety. They have to tell you. We have to tell the FDA. We have to tell the IRB. We're not hiding anything. We're highly regulated, as is all the other therapies out there. So the data is out there, but get it from the right place. I mean, I really implore people to do that. You're not helping by spreading misinformation. And second and third hand, we all know, second and third hand, things get distorted. So unless in that chat room, it's someone who is actually running a clinical trial, I wouldn't believe any of the information. I would go to the source.
And I'll say that we at the foundation are really happy to help put people in touch with the sources, with physicians and scientists who are working on this disease, knowledgeable about it. And we'll do that in as unbiased a way as possible. We have a pretty big connection list. And I can tell you the willingness and the motivation of the folks in our network to interact with patients and caregivers is incredible. People will spend large amounts of time walking you through what they're doing, what the rationale is. And unfortunately, at this point, there's no right answer. We simply don't have any statistical data that says what's the best way to treat this cancer. Maybe within a couple of years, there'll be a lot more information than that. And there are beginning to be some clinical trials or just interesting clinical studies, not necessarily in the formal context of a clinical trial, that are showing a lot of promise. But it's really early days and the numbers are still small. And so people are being asked to make tough decisions on the basis of limited information. All right, enough.
Can I just mention one other thing about immunotherapy that we've learned? Again, we've studied thousands of patients now, not fibrolamellar, but thousands of patients on these immune checkpoints. And the side effect is autoimmune. So basically what that means is an antibody can develop or a T cell can develop against a normal tissue. But we can now, in the majority of cases, anticipate that so that it's a very mild problem. What we do is we stop the therapy. Sometimes we put you on steroids for a short period of time. When we've done this, often patients, even off of the therapy, even treated with steroids, their tumors continue to regress, to shrink. And so it's very important that it's a different kind of toxicity from the toxicities of chemotherapy where they actually kill normal cells. And there could be nausea, there could be vomiting, there could be liver damage, all these sorts of things. So I just want it to be clear that, whatever information is out there about the toxicities of immunotherapy, in my mind, they're nothing compared to chemotherapy and some of the other therapies, and we can prevent them. And in fact, when we stop the therapy, sometimes patients continue to respond. And we've had only one patient have a side effect like this on our trial, and we took them off the therapy. They're doing fine, and their tumor continued to shrink. So again, not sure what information's out there, but I just have to be, I have to say this very strongly: ask the experts.
And I want to thank you because you actually answered a question that I was going to throw out, which was how problematic are toxic effects of immune checkpoint inhibitors, and I think you just covered that really well. Paul, maybe you could pick up another question that's come in, which is an interesting one and something, again, people have become aware of because of some of the COVID vaccines. Question is, there are some vaccines which are mRNA, there's some which are protein, there's some which are other types. If you're thinking about a cancer, is there much of and we should say there are people who are talking about mRNA vaccines for cancer, just as there are mRNA vaccines for COVID now. what is an mRNA versus a peptide vaccine, and are there advantages or disadvantages at this point?
Sure. So an mRNA vaccine is taking the protein sequence you want to teach the immune system and just encoding it in this nucleic acid, which is the same material your cells use to encode proteins and to have a blueprint for the protein that they're going to make. So it's working with the machinery of your cell and forcing your cells actually to make the protein that's then going to be shown to the immune system. One of the reasons that they probably, so one of the reasons why they're very useful in the setting of COVID is that they can be made and changed very rapidly. So it's easy to make RNA in many ways. And as soon as you have a sequence on your computer, you can have a machine make that RNA. And so that was one of the reasons why it was used to accelerate this process so quickly. Another reason why they probably work so well is the way that they're delivered provides this sort of accelerant that Liz was talking about to the immune system. So RNA itself, actually, when it comes in from outside the cell, is sort of something that cells think is a problem, because that's exactly how viruses work. Viruses have RNA in them, and so there's lots of machinery in your cell to say if RNA comes in from the outside, it could be a virus, and so they get very excited and start asking T cells to come look at the situation. And then also the way the Pfizer vaccine and the Moderna vaccine were packaged was in these sort of lipid droplets that were also sort of inflammatory, that got your cells thinking that this could be a problem. But as Liz was saying, it's really important to not necessarily get caught up in sort of big picture comparisons that might not apply to your specific situation, because there are good RNA vaccines and there are RNA vaccines that aren't working. So it'd be really critical, even for COVID. So it'd be really critical to know the specific trial that you're going on. What platform is it using? Has it been used before? Why would it work for you or not? And that's going to involve talking to experts. And so just to give an example from COVID, we know Pfizer, we know Moderna, they're both working. It's great. It was just recently reported of a trial from CureVac, which was also an RNA vaccine, and it didn't work. Exactly the same antigen, but packaged slightly differently. They used a sort of a different way of making the RNA, and it's probably not moving forward anymore. Similarly, there's a protein vaccine from Novavax, which is very similar to a lot of these protein vaccines for cancers, where you've got a peptide, you have an adjuvant, which is that accelerant for the immune system. And it's working phenomenally. The trials look beautiful. It hasn't been approved in the US yet because of sort of regulatory, paperwork type reasons. But that's probably going to actually be a really useful vaccine for us, particularly when it comes to if there's ever going to need to be a booster shot. And it's, you compare the antibodies they elicit, protein, RNA, if it's the right vaccine, same antibodies, same T cells. Both platforms can work really, really well, but it's got to be the right platform for the right situation.
Thank you. One of the things we've seen in the whole history of cancer research is that different modalities of therapy or different specific agents wind up in time being used in combinations. And at least for the old days of sort of classical chemotherapy, which is mostly just things that kill cells, not in such a targeted way, it was still necessary to use combinations in many cases to get to the point where individuals were being cured. Now we're seeing different kinds of combinations of chemotherapy plus immune therapy, or sort of things that are in the gray zone in between, like an interferon, which can kill cells but also has activity on the immune system. We hear about effects of radiation of a tumor suddenly changing the immune response to metastases way elsewhere in the body. How are we going to start navigating for this cancer and others the best way to get to the most effective combinations when we start thinking about multimodality therapies? Liz, you want to take a crack at that? It's a little unfair to ask such a broad question, but
yeah, it's a very complex question, as you're pointing out, and we're trying to better understand radiation. We do believe, and there's a lot of animal studies to suggest that radiation together with different forms of immunotherapy may work. The problem with studying radiation, one, is that there's so many different forms of radiation therapy. And also radiation, we do know a lot about radiation therapy biology in that it's a very dynamic process. There's the acute changes over hours, there's subacute changes over days to weeks, and then there's the chronic changes. And so what we don't know is the best time to be able to integrate immunotherapies with radiation therapy. I do have some really close colleagues who at other institutions, as well as at Hopkins, who've been working on this for a long time, some radiation biologists who are fabulous, who are showing some really good results, but most of it being preclinical, because one of the problems trying to integrate different therapies clinically, well, there are two major problems. One, you really, to understand these changes, you can't really take a blood test. You have to get a piece of the tissue and see the changes. And as you know, it's not ethical to keep getting pieces of tissue from a patient. There's a lot of risks in doing biopsies. And so if you have changes occurring with radiation, many changes occurring over, several weeks to months, you're not going to be able to really study those. So that's one major problem. So the second problem is we don't have good blood tests to tell us how those changes are occurring at the tumor, whether it's due to radiation or chemotherapy or immunotherapy. We wish we did, because that would help us tell us how best to integrate other therapies. People are working on that for sure. They've been working on it for a long time. We call it biomarkers, but there aren't too many biomarkers out there that really can help us, that we can sample in the blood, which is an easy place to sample. Another way to be able to study this would be with imaging. And again, our imaging is just not specific enough to look at these very small molecular changes that are occurring in the tissues. So we still have challenges technologically that many people are working on, but we haven't solved.
Thank you. So we just got a question which actually raised a point we talked about before we began the panel. And it's really about, what do we know about immunotherapy for hepatocellular carcinoma? And what does that teach us about immunotherapy for fibrolamellar? And, either immunotherapy or vaccines. And maybe one could even generalize that. And I'll even put in a little bit of a plug. I think people who work on fibrolamellar, all of the researchers I know who work on it, will tell you these are really different cancers. They occur in the liver. And even when you look in the pediatric group, where you tend not to have cirrhosis in as many patients, even in that context of non-cirrhotic liver, there's clearly a difference between HCC and fibrolamellar at many, many different levels. So much so that we're actually asking, as a foundation, we're putting in a petition that the coding system for cancer make a clearer distinction between hepatocellular and fibrolamellar. And that goes right down to the level of how insurance companies wind up paying for treatment. But with that said, Liz, could you talk about the differences between hepatocellular and fibrolamellar?
Absolutely. And in fact, that's a fabulous question. So thank you for asking that. So they're very different. So you start with what causes them or how they develop. And so you've heard from Paul and myself that fibrolamellar is probably a specific genetic alteration to genes fusing and making this new protein that actually drives the development of the cancer. Well, with HCC, hepatocellular carcinoma, it is very complex. And in fact, there's no common genetic alteration that drives it. There's multiple different genetic alterations that lead to inflammation of the liver, cirrhosis, and then cancer. There's viral causes, hepatitis B, hepatitis C, but in the United States, it's actually becoming an epidemic, or will be soon, because of obesity, because of other reasons, non-viral reasons. Now, they all lead to cirrhosis, but we still don't understand how they get to cirrhosis, because if you try to do genetics on these cancers, again, it's a very complex story. However, it's interesting. And so it's very different. The treatments are going to be very different based on that alone, based on how these different cancers develop. But interestingly, a good point about you have cirrhosis versus you have the stromal fibrosis in fibrolamellar. And it turns out that cirrhosis and fibrosis are probably very different. And in fact, fibrosis in one disease or one cancer is going to be very different from another because it's not just one cell type. There are multiple cell types that make up the fibrosis. There's multiple cell types that make up the cirrhosis. And so what we're trying to do, this is a whole field that's just gotten started, and we're trying to better understand what are the differences between these different fibrotic, cirrhotic forms. And I think that's going to be a real clue. Like I mentioned before, these are a big barrier, big wall around the cancer that prevents treatments from being effective, from getting in and being effective. Why now? Why are we starting to look at it now and we didn't before? Because until recently, we didn't have the technologies such as single cell analysis, we call it, where we can take a biopsy and we could look at each individual cell and look at the 20,000 different signals within each cell that drives that cell. Now we can do it, and we could do it in real time. And so in a short period of time, in weeks or in days rather than in years. So these new technologies are really enlightening us to what are the differences. And so I'm hoping that that's going to be a new piece to the puzzle for fibrolamellar cancer, for hepatocellular cancer, for some of the other cancers where this fibrosis or the stromal reaction is very important to drive or to help the cancer progress.
Thank you. I want to turn just for a second to a slightly different kind of question. And Paul, maybe let me throw this to you. There are institutions now which are beginning to elevate fibrolamellar from being something nobody'd ever heard of, quite literally, in their oncology group, to actually focus on having clinics for patients with fibrolamellar, or are beginning again to run targeted clinical trials as is happening at Johns Hopkins. I know that there's been interest in St. Jude and also with some of your other colleagues in Memphis at University of Tennessee in coming up with programs that really are going to be helpful for fibrolamellar patients and ultimately maybe leading to immune therapy. But could you talk about how your institution deals with a rare cancer and how you sort of tackle the problem of something which people don't see very often, and want to be able to help patients in the best possible way?
Sure. So that's a great question. So St. Jude is a somewhat unique institution in that it was founded to address catastrophic diseases of childhood and quickly focused on cancer as the primary focus. And in a lot of ways, pediatric cancers broadly are rare cancers, which thankfully they're not as common as adult cancers. And so the whole mindset of the hospital is really around how do you deal with special cases where, as Liz was saying earlier, you can't do 10,000 person clinical trials, and you have to be really thoughtful about how you bring therapies forward and try to learn as much as you can from every trial that you do. And so I would say, the patients that we see here at St. Jude are generally always on some form of a research protocol. The point of calling St. Jude is that St. Jude is the patron saint of hopeless causes. And so the idea was that the cases that would be dealt with here are cases that didn't have a solution anywhere else. And so everything is a research protocol, and every research protocol is designed to collect as much information as possible so that we can learn exactly how the therapy, whatever the therapy is, was working or not working during the trial. And as Liz said, this is just getting better and better in terms of the resolution that we can do this at. We don't need a lot of tissue, or often now even just from the blood, we can learn so much about what's happening when a drug or an immunotherapy has been applied, to then try to say, what were the circumstances of this particular patient that led to that particular outcome. And so if a patient so every patient that comes here, and I'm sure at other institutions, initially they would be tried to be fit into sort of an ongoing protocol. If they have to be treated off protocol because there's just nothing that fits for them, then the sort of collective nature of their disease and the presentation and the special circumstances of that patient are taken into account to develop some kind of therapy that's scientifically informed, that would have the best shot at working given their history of treatment and so forth.
Yeah, we heard from Liz Jaffee earlier about just the importance of bringing the science and the clinical medicine together, and what Paul just emphasized of learning as much as you can from every patient that you treat, both trying to benefit the patient to the greatest extent possible, but also to understand that part of what's precious when a patient volunteers for a clinical trial is that essentially they're saying, I want to help you get information about this disease that will help me and everybody else with it today and in the future. And that's something the foundation works very hard to help bring people together at multiple levels, talking about research networks and clinical networks, and that's something that's going to happen. Liz, in a rare cancer, how hard is it to get to the point where you can get to the Food and Drug Administration and say, we haven't looked at 10,000 patients because that would take years and years and years and years. How many patients do you actually have to see a result with and understand the science with to get to the point where clinical practice is going to be changed in a way that the regulatory agencies will actually agree with and say this is becoming something closer to a standard?
It's a great question. I think that the FDA does have, I know that the FDA has pathways for rare diseases. So, if it's going to depend on the number of people who are responding within the small group, also the quality of the response. And then again, you want to look at the risk versus benefit. And so I would say that you don't need a lot of patients in this disease because it's such a bad disease if you can show true quality responses to the therapy. And, I've seen rare cancers with 30 patients responding, 30 patients and having a 50% response rate and the FDA approving that therapy. So I think whoever's doing the study has to really be able to prove to the FDA that the therapy has true benefit and the risks are minimal compared to the benefit.
Thank you.
The FDA is not, I just want to say, the FDA is our friends. The FDA wants to see good therapies, but the FDA wants to protect the American public. They're not the enemy. They facilitate. And over the years, I've worked with the FDA for a long time, and over the past 10 years, they have really accelerated therapies for these really bad diseases that are rare. So it's not an FDA problem, it's a therapy problem. We have to prove the therapies are good.
Great. I haven't seen a lot of question activity. We still have a lot of participants on the line. So let me just give each of you a minute or two to ask if you have any final thoughts, things you'd like to convey to the folks who are out there listening. And then we'll thank everybody for what I found a tremendously helpful discussion. At least I've learned a lot. I hope everybody else has. Paul, do you have anything you'd like to leave as a last word?
Sure. I saw a couple other questions pop up that I could quickly address. So one was a really smart question about CAR T-cell therapy about, is it going to have a problem in solid tumors? It's a great question because this is exactly the concern in solid tumors. And, there's a number of trials underway now in a number of different solid tumors where, this is being looked at very, very closely. And so what I'm really hopeful for is that we're going to learn some tricks in these other tumors that we can then apply to things like FLC. It might not be the exact same trick in every tumor. So there are things like introducing other receptors onto the T cells to trick them to going into the tumor, even if the tumor is telling them not to come in. There's all of the area that Liz was talking about trying to deal with what we call the tumor stroma that's also trying to keep cells out. So getting rid of the fibroblasts, which is the cell type that likes to regulate what cells can come into a tissue. And so again, the solutions might not be universal in sort of the actual, drug or trick that's used, but the principle might be universal. And so then that could be applied. But it's exactly going to be the question that's being addressed, but at least that's being addressed by lots and lots of different scientists simultaneously in lots of different settings. And then the other question I just wanted to touch on, because it's a great question, was the last one that showed up in there, which is, should there be some coordination of the research? And I just have to say that, I, as Mark said, I came into fibrolamellar sort of late. I was a virologist, I was a parasitologist, I still am both of those things, and and started working on pediatric cancers and learned about fibrolamellar through some collaborations and then through the foundation. And the foundation's done a really good job of trying to establish those resources, particularly, the question mentions a data and tissue repository where we can get samples from patients that are undergoing different treatments and try to study them and study their immune responses. And so it is absolutely critical, I think, in settings like this where there aren't large number of patients locally, where we can enroll them all ourselves to collaborate and share with each other.
Yeah, and I can certainly say at the clinical level, we just had a meeting this week of our medical and scientific advisory board for the foundation, which Liz is a member. And there's tremendous interest among particularly the clinicians on that MSAB to make sure that there's tremendous communication amongst themselves, among the centers that are seeing a lot of patients, and assure people that that's going on all the time, even when there are centers that take different approaches to the disease. Because in fact, today, we don't know an ideal treatment for fibrolamellar, to answer another question. It's still an area where there are a number of different ideas being tried. There's new data coming in constantly. There are people doing creative things. There are people doing things that are showing, really for the first time, a higher percentage of patients showing real responses. And even within the 2 years I've been involved with this cancer through the foundation, I've seen changes in what we hear from the clinicians who are right there, at the forefront. And the idea of cooperation and communication is something that's been central to what the FCF wants to do for its entire existence, going back now 12 years. But it's something that this whole community seems to share, with very few outliers, honestly. Liz, I think we've covered now the questions that have come in. Is there something you wanted to leave people with as kind of a last thought?
I did want to, and I'll leave them with this thought and also answer another question in there that wasn't addressed, but about debulking this cancer. But I do want to reiterate, I think that the person who asked about collaborative work and getting the data out there, absolutely. You are absolutely correct. Thank you for asking that. I think the fibrolamellar cancer community, the researchers should be communicating, and I think the Fibrolamellar Foundation has really helped to do that. And I really appreciate everything that they have done, but we have to get all of the investigators working on this cancer to do this. There's no best treatment for this, but there are a lot of treatments out there. Some are more scientifically based than others. I think it's important to get the right information from the experts. I also think you should think about this cancer as one that you're trying to convert to a chronic disease. So it's not going to be one best treatment, but you might want to try multiple treatments at different time points. And again, your oncologist can guide you as to when that is. And we have found with immunotherapy and in this cancer that we can get many of the cancers to regress. And then we take the patient to surgery to get the rest of the last piece of cancer out, or one lesion that hasn't responded well when all the others have. So we do combine multiple different therapies to try to keep a patient feeling good and dealing with this cancer until the best treatment is finally available. I am an optimist, I'll be honest, but I really also want to get across to everyone that we are in an amazing time in biomedical research in our technologies, and we're making advances very quickly. And so please just keep looking for the best treatments, and you may have to try a number of different treatments over time to keep the cancer under control. But at some point, I truly believe that we're going to find better treatments for this disease.
Thank you. A couple of other things that have come up. I wanted to talk just for a second in response to the question about the difference between immune therapy and targeted therapy, because we use the word targeted very broadly. And we even talked about we want to target specific antigens or so-called neoantigens. But when people talk about kind of the way the word targeted therapy evolved out of the field of cancer genetics, of trying to target therapies to what we know is genetically driving the cancer, that generally referred to the more classical drugs. And often these turned out to be inhibitors of enzymes that carried out biochemical steps, such as protein kinases. And the question was, are those immunologically based? And the answer is, at least to the first approximation, they're not. They're really designed to attack the chemistry of the tumor cell. Whether that has some additional corollary for whether the immune system also responds is not often clear. And sometimes it can be positive, sometimes it can be negative, because immune cells can be rapidly growing cells just like tumor cells, and sometimes they use the same enzymes to grow that tumor cells did. But if you think about drugs like sorafenib or lenvatinib or some of the others that are used a lot in HCC, and sometimes are being used in fibrolamellar without having any clinical data yet that really says they work in a published form anyway. The mechanisms are different, and they're not primarily intended to boost the immune response. They're really primarily intended to attack some aspect of the tumor. Might be how blood vessels get into the tumor. It might be actually something the tumor itself is using as part of its growth signaling and programming for growth. But these are really distinct kinds of therapies. And again, it remains to be seen in the future whether combinations or alternation of those things or just an array of therapies will be the most effective, as Dr. Jaffee was just saying. Okay, folks, have I missed anything? We're getting very close to where we were going to cut off. So let me take the last couple of minutes to thank Paul Thomas and Elizabeth Jaffee. I think you've been fabulous panelists. This has exceeded my own expectations for a lot of fun as a conversation and thought-provoking for me, and I hope for the audience. And let me reiterate that Paul, Liz, and all of the investigators I know who are affiliated with the foundation or not, who have dealt with this cancer, are keen to talk to patients and family members, are willing to do that and eager to do that, to tell you what they know, to talk about the science they're doing, to talk about where that may lead to better medicine. So feel free to reach out, as Dr. Jaffee and Paul have both said. We're here. You can reach out to me through the foundation. I'm happy to either tell you what I have learned or put you in touch with people directly. And I think that's true just across the boards for this disease. It's rare, it's difficult, but you're not alone.
Yeah.
And with that, again, thanks to you, thanks to our audience members for some fantastic questions, and thanks to the scientists and physicians who are at the front lines of trying to find better ways to treat this disease. Thank you very much.
Bye-bye.
Bye-bye.